Hi there, everybody. Good afternoon and a great big welcome on behalf of Breast Cancer Trials to today's session. My name is Annabel Crabb. I'm beaming to you from my house, which is on Gadigal land, occupied by the great Eora Nation. And this is as close as we get to being all together in this very, very strange year. I know that the last couple of years have been massively disruptive in terms of treatment, diagnosis and living like a normal human being. And there is something quite wonderful, even though we're on Zoom, about knowing that there are around about 1,500 people gathered here to talk today about some really important things. Welcome to the Breast Cancer Trials Q&A on the topic of breast cancer and sex. Now, cards on the table. I am the veteran of only one of those phenomena, but I'm here to learn from our expert panel and from you with all of your questions and observations on this subject. Breast Cancer Trials, I'll tell you a little bit about, is one of the world's leading breast cancer research organisations. They've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978. And just for context, this year, more than 20,000 women will be diagnosed with breast cancer in Australia and more than 3,500 in New Zealand. Now, like many of you watching, a lot of women will struggle with a range of issues like body image, low libido, and menopausal symptoms, but they're not necessarily the things that people always talk about when you discover that you've been diagnosed with breast cancer. And so that's the point of today, really. Breast Cancer Trials wants to ensure that all of those women know that they're absolutely not alone and that there are answers out there and help. So we've assembled a great panel of experts this afternoon, and we have made the pledge to ourselves that this will be an awkwardness-free zone. You will not be talking to someone who's not quite meeting your eye, and you will not be having any awkwardness in the questions that you want to ask. We're going to be talking about vaginas. We're going to be talking about nipples. There is nothing that is not on the table. Now, and we know that there is a demand for this because there's about 1,500 of you on this line. So there's a lot of conversations that people want to have. I want to open by paying respects to and acknowledging the traditional owners of all of the postcodes from which we hail today. Way too many to list, but we want to honour the tradition of the Indigenous owners of this great landmass and their traditional commitment to healing and to communication and to listening to each other, which is what we're going to be doing today. I'd like to introduce you now to this panel that we've put together this afternoon for our awkwardness-free zone. They will be answering all of your questions around breast cancer and sex. Firstly, the legendary Professor Fran Boyle, who is the director of the Patricia Ritchie Centre for Cancer Care and Research and Professor of Medical Oncology at the University of Sydney. We also have Ms. Rebecca Angus, who's a member of the Breast Cancer Trials Consumer Advisory Panel. We have Dr. Belinda Kiley, who's a medical oncologist and staff specialist at Concord and Campbelltown Hospitals. And finally, we have Professor Kate White, who's a Professor of Cancer Nursing in the Faculty of Medicine and Health at the University of Sydney. Now, we're going to get to all of our panel and have a nice long chat, and then we'll start firing questions at them. I want to start with you, please, Rebecca. I wonder if you could just run us through your own history and experience with breast cancer. When were you diagnosed and how did you find out?
Yeah, I was diagnosed 3 years ago. I was just about to start to go back to work off maternity leave. I'd had a lot of mastitis through my breastfeeding of my son, and I decided I'd had enough. So I was weaning and noticed a hard lump about 12 o'clock. In my breast, and also I was lactating from that left breast. So I went to my GP who sent me for an ultrasound. The day of that ultrasound, I got a mammogram and a core biopsy on the day, and within 24 hours, my GP was on the phone telling me I had breast cancer.
So how old was your baby at the time?
He was about 10, 11 months old. So I basically had surgery about a week after that. And then a few weeks after that, I had his first birthday, and I had a drain still in my back, and people didn't know I had breast cancer. I was hiding it. I was hiding it in a handbag. So it wasn't until I started to lose my hair when I had chemotherapy that I had to actually start acknowledging it and also sharing it with my friends and family.
Wow, Rebecca, just even having a 10-month-old, I found so disorienting. I mean, just in terms of what it does to the rest of your life and your routine and your idea of yourself, and your kind of mental health is always up and down in these sorts of times of transition. What does it mean to actually chuck in breast cancer on top of that when you're trying to work out how this baby works with your career and so on?
Yeah, well, look, I was really excited to go back to work, but obviously breast cancer had other plans, and certainly it wasn't on my radar. I was just about to start extending my family as well. So having a baby and having breast cancer at the same time it's crazy. Definitely wouldn't recommend it to people. But I was very lucky. My oncologist was amazing. And in the beginning of my treatment, she said to me that if I could afford to put my son through daycare full time, that was like the best option for me. And so that's what I basically did. It gave him quality of life and normality through a period in our life that was all over the place. So, yeah.
So what about your relationship? I mean, that's quite a lot of stuff to throw at any relationship, right? Like, how did it affect yours?
I think probably in the beginning, we were just trying to go day by day. And I think that I'm very lucky. My husband is very supportive and has been my teammate throughout this whole process. He never put any pressure on me and just allowed me to navigate this disease, and he's just been there by my side the whole time. So I'm very grateful to have his support.
So if I were to guess at what your first, let's say, 10 top of mind thoughts were when you got this diagnosis, I bet what's this going to mean for my sex life might not have been up there, right?
Yep.
How long did it take you to start thinking about that, or noticing changes, or thinking that this was something that you might want to ask your medical team about?
Yeah, so in the beginning, obviously sex is discussed, but in medical terms. So it's more about fertility preservation. It's about contraception while you're on chemotherapy. And in the beginning, you're kind of not really feeling very well. You don't look very well. You're starting to lose your hair. You kind of lose your whole sense of identity and who you are as a person, your body image. And so you're not feeling great. So sex isn't really high on that list, as well as the fact I suffered from terrible fatigue throughout my treatment. But over time, you realize that sex is an important part of any relationship. And it was very hard at times because I did feel guilty that I possibly wasn't meeting the needs of my husband, and that, this was all going to be too much for him. So, but I think over a period of time when you start to get used to your treatment after treatment and after chemotherapy, and when you're starting to feel better, you are exploring it more. And that's when you start to realize that things aren't exactly the way they were before you were diagnosed with breast cancer.
Okay, so what sort of changes did you notice? I mean, I guess you've got the initial response that is literally a survival response, right? And once you're out of that part of the woods, then you start looking around and assessing what else in the landscape of your life is not the way that it was before. So tell us what that involved for you.
Well, with that sense of body image and loss of identity, I probably didn't realize how much, my surgery, I'd had a lumpectomy and axillary clearance for my surgery. I was told that I was going to lose sensation in my left breast. But as we all know, that a breast is an erogenous zone, and, that did have an impact on our sex life. The other thing is obviously through my treatment, I've had to have tamoxifen and ovarian suppression. And so I'm in menopause, medically induced menopause, in my 30s. And so I really didn't realize what that would mean. I only had my mother to guide me through the process, and none of my peers were going through similar things. They were still extending on their families. So I had no one to talk to. I was having hot flushes. I was having insomnia at times, and I had vaginal dryness as well. So I'm very lucky that I am proactive and I do try and ask questions when needed. But yeah, it wasn't much fun, let me tell you.
Yeah, and there's just no way of saying vaginal dryness in a way that sounds interesting or exciting, is there? It's just, it's not a fun concept. When you were talking a second ago, you talked about your sense of feeling guilty, and that just breaks my heart to think that you felt that way. But I bet you anything that it is kind of like a common feeling, right? Like this feeling that because you're tired, because you don't, have the energy to do all the things, for your children and for your husband and with them, not as a service, but as a, participation in the joy of your relationships with people that you love, that you would sort of shoulder that as personal guilt, even though it wasn't your fault. How did you get around that?
Yeah, well, so I did. I really felt my body had failed me, and I'd failed everybody because, I think that, you put people through so much trauma with their breast cancer diagnosis. So one of the biggest things I did early on was go and get mental health support. And that really, I had mental health support throughout my whole treatment. And I feel that was very helpful in making me acknowledge that these are normal feelings and that other people feel exactly the same way as that I do, and that it is not forever, and that there is people out there that can help you with them.
And did you feel, I'll make this the last question, so we'll move on in a second, we'll come back to you in a little bit, but did you feel, just out of interest, that the additional steps that you took to address your mental health in conjunction with your breast cancer, did that teach you or give you any skills that were useful beyond your coping with the disease?
Yeah, I guess probably it's made me learn to be much more kind to myself. I think that's one of the biggest things. I'm a pretty determined person, and it's made me much kinder to myself, the way I view myself as a woman, and accepting that, it's okay if you're having a bad day, or it's okay you're feeling fatigued and you don't want to do something. I think it's really important to acknowledge your limits, and so I think it has helped me navigate that a little bit more and pace myself much more post my diagnosis.
Well, thank you for being here with us today, because I bet there's hundreds on this line that are feeling that same sense of loneliness. And, when you experience something for the first time, you always think it's unique to you, right? Like, so looking around and seeing that there are other people having the same experience is just an incredibly useful thing. So thank you for being here with us this afternoon. I'm going to turn to you now, Fran. I wonder, what is your experience, having worked with innumerable people going through the same sort of thing that Rebecca's encountered? What is the common experience about breast cancer treatment and the impact that it has on people's sex lives?
Annabel, I think it can vary enormously from person to person. And we often think about people in Rebecca's situation, and, you'd have to be the most clouded oncologist ever have walked the earth not to think what she's going through must have an impact on her well-being. But sometimes the people that we don't recognise as having difficulty might be people who are around the age of natural menopause anyway, and it's often difficult for them to tell the difference between what's happening with their cancer treatment and what might be happening in their, let's say, around the age of 50 with their menopausal symptoms anyway. And then, of course, we always forget that older people have sex lives too, and that and that they may be already dealing with a number of other chronic health problems that might affect their sex life. So when you add, let's say, vaginal dryness to arthritis or spinal problems or diabetes or other things that affect your sex life, the things can really compound. And so we do know that the kinds of treatment that Rebecca had, where suddenly at the age of 30 you're in menopause, of course those hormone shifts are going to affect many aspects of your life. But hormones are a part of life kind of all the way along. And the effects of what's the breast cancer treatment and what's normal life and what's other problems, including other mental health problems, is really part of what we need to be more skilled at teasing out. And I'm sure Kate will return to this subject of working out what's what.
How has your profession come to think more broadly about treating patients in these circumstances? I mean, what is it that's driven the kind of evolution, I guess, from just spot treating the disease and not thinking about whatever else is going on in the patient's life?
I think a number of things have affected that, Annabel. The first one is improving survival rates. So when most people died of their breast cancer, how it affected your sex life didn't really get a Guernsey in the conversation. And then as survival rates began to improve, it was all about treatment, and more treatment. And I heard a surgeon on a trial planning committee this week talk about ovarian suppression as the relationship killer, and that we needed to find, better ways to help young women and not just layer more and more and more treatments on top of each other, and to try and personalise things more. But it's also very true that the voices of women who've been affected by breast cancer through the consumer advocacy organisations have been very powerful in bringing to our attention that they do expect to have life after breast cancer, and for life not just to seem longer, but to actually be longer and still fruitful, is something that really women have brought to our attention. And that probably hasn't happened as much in some other cancers as it has in breast cancer, and oncologists are grateful for that we've had that wake-up call.
How wonderful that this evolution is attributable in part to the success of the fight against the cancer. I mean, that is in itself an encouragement. I wonder, you obviously talk to a lot of women in this circumstance, and you meet a lot of partners as well. I wonder, what have you observed about the best way to talk to partners about this? I mean, they're obviously very frightened and panicky about what the road ahead might look like. Have you evolved any techniques or observed any patterns?
I've noticed that there still is a lot of reluctance among both women and their partners to raise subjects of sexual concern. And so it really behoves the oncology team, oncologists and nurses, to put that on your checklist of, how's your hair growing back? What about the hot flushes? Oh, and by the way, how's your libido? Now, pretty much always that gets a laugh. And being a bit of a clown, I always enjoy that. But the couple will look at each other and they'll kind of go, And so that's your opening to then have a better conversation about it. We also talk about dryness when we're talking about aromatase inhibitors, for instance. And they cause eye dryness, dryness of the skin, dryness of the mouth, and vaginal dryness. And if you just kind of run the list down like that, people go, oh, okay, that's normal that's on the list. Whereas if you were to start with vaginal dryness, you might, get people tuning out on what else you might have to say. And I think also, as Rebecca has identified, fertility is really the initial concern of great significance. And issues around sex tend to emerge a little bit downstream. So when we come to the end of chemo, discussing hormone blocking treatment, it really behoves us to start asking those questions then if they haven't already come up in conversation.
What are the common questions that you get from patients around sexual health?
Often I'm asked about whether it's safe to take vaginal estrogen preparations, and I'm asked by GPs and patients and gynecologists, etc. And I know this is an area of research interest for Belinda, so I might leave that question for her. But that's a very common one. The other very common one that we get asked about is menopausal symptoms, and in particular hot flushes. And we recognise that at the moment our treatments for hot flushes are not ideal, and probably the best evidence treatment are actually antidepressants, and particular antidepressants are safe to take with tamoxifen and with hormone blocking treatment. And they also help sleep and hot flushes. So that's sort of our go-to if someone's having a lot of difficulty. Now, as soon as you say antidepressant to some people, you've lost them, because they're saying, well, you're telling me this is all in my mind. And it's a little bit of a conversation to sort of get that across the line. But it's also the case that too much antidepressant wipes out your libido. And it's probably the only reason that they're not in the water supply, especially in a year like this, is that nobody would feel like having sex if we were all taking Prozac. Now, if nobody felt like it, it'd probably be no problem. But if only half the population was taking it, then you've got a mismatch in expectation. And I think Rebecca's story speaks to her expectations and her husband's expectations, and a need for conversation around that. And so a lot of the way that sex therapists work, they work with couples, they work at improving that communication and trying to get a better match between desires and how to make things work at a practical level.
Thanks, Fran. I'm going to bring you in now, Kate. Kate White, who's a professor of cancer nursing. At the point where someone's diagnosed with breast cancer, there's so many things to talk about, right? And it can be obviously super overwhelming, even for women who don't have a tiny baby and a return to work scheduled like Rebecca. At what point in the process should people be having a conversation about breast cancer and sex? And whose role is it to bring it up in conversation? Do you wait for the patient to raise it, or is it the health professional's responsibility?
I'll take the latter part of that question first. It's the health professional's responsibility. And I think the really important point, it's not a topic you bring up once. It's a topic that you go back to. I think it's important to raise it at the time of diagnosis, but you can do it in a way that says you may not want to discuss this right now, but it may be something that comes to mind as you go through your treatment, and we want you to come back and talk to us, and what the pathway is for the woman to come back and who she should be talking to about that. But if we're using a treatment that we know has a particular side effect, like putting someone into premature menopause, just like any side effect from any drug, we have a responsibility to ensure that they understand what that is. But not just what is going to happen, but that there are interventions or treatments that we can put in place to help manage those treatments or those adverse side effects. It's nice if the team have identified which team member's doing it, but I really think it's about everybody recognising it's their responsibility. It's not one individual person. And I think as a nurse, one of the really important things I've found helpful is articulating how a woman could bring this up. So for me, that's about, you can always talk to me about it, or you can always talk to this nurse about it, or breast nurse, whatever. But if you are concerned, let us know the day before that you want an extra 15 minutes, 30 minutes, because in a busy clinic, by the time you get there, and as Rebecca said, with a list of questions, particularly at follow-up, it kind of ends up being the last question on the list, and they can see that their consultant's getting busy, is sort of ready to wind up, so they can walk out without it. But if you actually contact people day before, the breast nurse or your medical oncologist, and say, I'd really like to talk to you about how the treatment's impacting my intimate relationships. That clarifies what's important to you so that we can focus on that straight away. And it's really important that we're asking about it frequently, to the point that, sometimes the women say, it's okay, stop asking.
Well, you say that it's something to raise a bunch of times, and I can appreciate that you want to kind of even normalise asking the question by not just sort of spitting it out and then leaving it forever. Can you talk us through what you must have had this conversation so many times. What are the commonest responses the first time you raise it? And then how does that change in the second and subsequent times that you raise it?
So often the first time it's, oh God, that's the last thing on my mind, because they're dealing with the shock of a diagnosis, and both partners and women are very focused on survival. It's about, and partners are really, I can see Rebecca nodding her head even though you all can't. It's about, what have we got to do that this woman that I love is going to be around? And so it's very much, oh yeah, tell me about it later. That's not true for everybody. Some people will be very concerned about it right up front, and that'll be a big issue. And I think one of the really important questions initially is really clarifying what's the most important thing for them at that time. And that's a question you can come back to, what's the priority area that you'd like us to discuss today? So I must admit, I get known as the nurse that's happy to talk about this. So, you do get, Kate, can we have that conversation now? But we've been working with the nurses who work in chemotherapy delivery, and sort of flagging with them that as part of that, as people come back in for their different cycles of treatment, that they actually ask them again, Now, I remember we discussed about how this may have an impact on things like vaginal lubrication. Has that been a concern for you, or has it had an impact on your intimate relationships? And you do vary the language depending on the woman, because some people, asking them about their sex life per se can be quite confronting. But the other thing I'd say is that it's not about sex. It's about intimacy, it's about sexuality, and it's about an intimate relationship, and how some of the physical changes and some of the ways that, as Rebecca sort of so beautifully articulated, that loss of confidence in their body affects their ability to maintain those relationships.
Obviously, some people are, like you are super happy to talk about it at length, and so you are the sex nurse, so that's great that you're available. But then I guess for some patients, as you say, some of them aren't up for the full conversation about their sex lives. There are people who might prefer to sort of slink away and consult some resources and kind of educate themselves. I mean, what sort of resources are available for patients to navigate through these super personal issues? And do you have any recommendations about where to look?
Yeah, the Breast Cancer Network of Australia have a book that actually, one of their booklets that you get as part of the My Journey kit, actually addresses this topic very well. And it sort of takes through some of the areas. Similarly, though a number of the forums are for patients only, I understand that it's a frequent topic on peer support forums, and they can be a really good source of information. But the other thing, because not everyone's in the city, I think it's really important to think, well, where would I get my support if I'm in a regional or a rural community? And I think we shouldn't forget general practitioners, particularly if you have a general practitioner in town who is known as the women's health GP or women's health nurses. It doesn't have to be back at the cancer centre, and they often have a range of expertise in this area that can be really useful.
And are there any resources that you think are useful, or courses of action you think are useful for men to consult? Because obviously you'll have circumstances where, like Rebecca, you could hear in her voice, she's concerned about her husband's response. And I guess when something massive hits you as a couple, I mean, we're assuming heterosexual couples here, which isn't always the case, obviously, but, your first instinct is to protect each other. And sometimes it makes it hard to talk about frustration or guilt or, all of those other emotions. And I think, sometimes it's particularly hard for men to talk about that stuff. Is there anywhere where you would point blokes undergoing this situation?
Yeah, so one of the, Rebecca highlighted that she accessed some psychological support, and that support's available in all these cancer centres for both the patient and their family. So that's someone who would be available, would have an understanding of the cancer setting. They have tried over many years different sorts of partner support group, and they tend to fall over. Often what I have found is big workplaces often have other people who've been there beforehand, other men, and they create an informal sort of support network. And so sometimes it's about reaching out and knowing what's out there. One of the things that I would say, though, is it's about not necessarily definitely reach out to those. But one of the things we don't talk to couples about or don't talk to women about is about the importance of maintaining communication in the relationship and having that ability to have a conversation where you can talk about what it's like for both of you. Now, sometimes that isn't really a place you can get to until treatment's finished, but it can be that thing where you sort of just sit down and say, well, that was the roughest 6 months we've ever had. I know what it was like for me. What was that like for you? And it's about the couple that to me is the really important thing. It's about the communication that's going on there and giving both people the permission to say what didn't go so well or what they'd like to have happen. A conversation that's along the lines of, what have you noticed? Things seem to be different between us as far as physical relationships. Is that something that's worrying you? Could we talk about it? One of the things we know is that often couples don't talk about sex. They just do it and it works. So when something comes along and it no longer works, it's like, how do I bring this up? How do I talk about it? And for the patient, it can be really hard because, as Rebecca said, they're fatigued. They haven't got the physical or emotional energy to actually drive that conversation, particularly going through treatment. But it is about doing that. And I think the reason why I'm saying this is so important is when you've got one person in a relationship who's receiving care, you can shift the relationship from being a partnership to being someone who's unwell and someone who's a carer. And it's kind of hard to feel sexy about your carer or your patient, that we don't do that. So in getting them to talk and re-engage on an intimate level, that's how you start to get that relationship going again. Rebecca's smiling at me. I can see her, so I'm hoping I'm saying the right thing.
Yeah.
Okay, there's such great observations. You can tell the depth of your experience just from the way that you talk about this. I'm going finally now to turn to Belinda Kiley. Now, Dr. Belinda Kiley is a medical oncologist, staff specialist at Concord and Campbelltown hospitals. Belinda, I wanted to ask you, we've heard, and it's sort of a great piece of insight that that improved treatment for breast cancer has generated more survivors. They can spread the word, I guess, and build this sort of question about what life is like after breast cancer, which 25 years ago was not really a predominant conversation. So that's a great thing. But is there much research into the improvement of a patient's quality of life and the side effects they might have as a result of treatment?
Great question. I think that with breast cancer, I guess everybody's focus is always on curing it and survival, and certainly the treatments over the last 20 years have improved significantly. And as we've been saying, people are now living a lot longer and most people are now cured of their breast cancer. But I think that probably is a lag in the research looking at, well, what are the symptoms of the treatments or the side effects of those treatments and what can we do to improve those? And I think that does lag. I think actually it's one of the areas that Australia does quite well in. we seem to be quite good at doing sort of quality of life and symptom research, but we certainly need to be doing more of it. And I think in breast cancer, often the treatments that are more effective, that make the bigger differences, have more side effects. And so we've been talking about the hormone blocking medications this evening, and the more effective of those are the ones that cause the worst symptoms, the ones that lower the estrogen the most and cause the worst side effects. So I think we need to do a lot more research into improving those side effects, because unfortunately these treatments are only going to be effective if people can take them and stay on them. And I know a lot of oncologists have patients that stop their treatment because the side effects are too severe, and a lot of women stop the treatment because they're having bad effects on their libido or their vaginal dryness or their hot flushes, and they're so intolerable, their quality of life is so bad. For them, they end up deciding to stop the treatment, and then they're putting their cancer and their risk of recurrence becomes higher, and that's terrible. So I think these treatments are great, and they're effective treatments, but we need to make sure people can take these treatments in a way that their quality of life is not so impacted. So yeah, definitely an area that we need more research, but I think Australia has been good at leading some of this sort of research.
You're yourself currently conducting research into the prescription of vaginal estrogen to women with breast cancer. Can you just give us, I am a novice in this area. Can you tell us about that treatment and tell us about your research and why it came about?
Yeah, so I guess I see women with breast cancer every day in the clinic, and I see that so many of them are troubled by vaginal dryness. So when women go through menopause and their estrogen levels drop, the vaginal tissue gets thinner and less elastic and less lubricated and dry. And there are moisturisers and lubricants that can be used, and for some women that's very helpful. But for other women, those lubricants and moisturisers don't work. And there are vaginal estrogen creams and tablets and pessaries available that can actually be quite effective. And so there has been some research with vaginal estrogens in women postmenopausal without breast cancer. But with breast cancer, there's such a fear about using anything with estrogen or hormones in it because of the hormone replacement therapy studies that were done years ago showing it increases breast cancer. There's just this massive fear out there about any sort of estrogen. Now, the vaginal estrogen products have got extremely low dose estrogen. It's been used locally. So I guess I would like to sort of get a bit more data about how effective are these treatments in women with breast cancer and how safe they are. And so fortunately, breast cancer trials have given me some discretionary funding to start off with a small study, just seeing if we give vaginal estrogens to women, does it help their symptoms? What does it do to their estrogen levels? And how comfortable are they using it? Are women just so terrified of using it that they're not going to take it, or are they actually happy to take it and use it? And it's certainly not a treatment for everybody, but I think that there are some women that this can be really helpful for. So I'm hoping to sort of get a bit more data to find out how effective and how safe are the vaginal estrogens in women with breast cancer.
So, Belinda, I guess you'd look back at the last 2 decades and you'd look at breast cancer as this sort of incredible success story, research-wise, I guess, and treatment-wise. It certainly had this sort of trajectory that other cancers, sorry, I keep talking about cancers as if they're actual, entities. But is it hard to get enthusiasm for research that's into not straight survival and treatment per se, but into side effects? And is it different for breast cancer than for other cancers that are predominantly experienced by men, for instance? What is the appetite for funding research like what you're doing?
Certainly, like you said, there's a lot more interest and funding and recognition of studies that will improve survival. I think because, as we have been saying this evening, breast cancer is one of the cancers where people live a long time. So we've got a lot of women who are surviving their breast cancer and living with their breast cancer and dealing with the side effects. And they're the voices that are pushing for us to do research to help. So I think in recent years there has been more of a move towards patients reporting their own outcomes and us looking at what are the symptoms patients are experiencing and what can we do to improve that. And I think also recognising if we don't do this research, it doesn't matter what study we do to say this drug's going to be the most effective for cancer. If women can't tolerate it, then it's not going to be able to be used. And so I think that we're trying to get more recognition of this sort of research, and I think that is happening. And I think Breast Cancer Trials has been quite good at supporting my study and some other studies like this, looking at improving quality of life and symptoms. And so I think there is funding for this sort of research. It is research that can be done in Australia. A lot of the studies that studies that look at sort of treatments that improve survival need a lot of countries to come together and enrol thousands of women. So we can do sort of more smaller studies in Australia that are more local, that can be quite impactful if we can show that we can improve symptoms and improve side effects and keep people on their treatments.
Thank you, Belinda, and thank you to the whole panel for giving us your opening thoughts there. And now is the point at which we're going to turn around the microphone and take some questions from the hundreds and hundreds and hundreds of participants in this session. We've taken a lot of questions already, and I'll be dipping into those just in a minute. But I thought for now, we might just give you a sense of the sample and the range of questions that we've received, because I am absolutely assured that the response to this session already has been absolutely spectacular. So we've edited together this little selection of some of the questions that have come in. I think you can get a sense from that little assembly that there are a lot of people really desperate for more information, some general and some incredibly specific about their own situations. So now we're going to turn to our panel and start finding some answers to some of those questions. And so I'd like to welcome back our excellent panel, Professor Fran Boyle, Rebecca Angus, Dr. Belinda Kiley and Professor Kate White. Before we start answering questions, I will warn you that there is some sort of meteorological event happening around Sydney. Maybe it's just New South Wales getting even with the earthquake in Victoria last week, but there is a very large storm that's about to hit. I'm hoping that that won't affect our transmission, but if you do hear the odd clap of thunder, it's not sort of a response from God, the discussion of these forbidden topics in any way. It is really just thunder, so try not to be alarmed. Now, when we put these, opened up this area for questions, there really was an overwhelming trend about in the questions that people wanted answered, and it really centered around libido. That was a very common line of questioning among the inquiries that you've sent in. We've received questions about poor libido from women who are either going through treatment or at the end of their treatment or even several years past their breast cancer treatment. And Fran, I'd like to start with you if it's okay with you. And the rest of the panel can chip in along the way. What can women do to improve their libido? And is it different depending on whether you're currently going through treatment or several years post-treatment? How does it vary and what can you do about it?
So it is possibly the great unanswered question of our time, Annabel, not only in women who have breast cancer, but in women generally. And if I had to guesstimate as a woman generally, I would say fatigue and the pressures of modern life actually have a lot to do with it. So I read a survey some time ago about our grandparents and how often they had sex. And apparently it was quite common for people to have sex on Saturday nights. That was a sort of normal thing that people did. And in fact, it was sort of almost an expectation of wifely duty, as Rebecca has pointed out. But also one of the things about that is that it means that people habitually put aside the time for their relationship and for intimacy. And I suspect Saturday nights now end up being Netflix and, half a bottle of wine, which don't actually do anything to help your libido as you, snore in front of the TV. And so for modern couples, the challenge is getting back in the habit of having sex as part of the story. So if after breast cancer, people are expecting that moment will suddenly come when desire strikes and they can spontaneously leap at their partner, it possibly isn't going to happen. However, making a deal with your partner to choose a particular time of the week, let's say Saturday night or Sunday morning or some other time when the kids are out of your hair, where you actually set aside a time for your relationship and for intimacy and get back in the habit of spending that time together, or perhaps don't get out of the habit, then it's going to be probably easier to be aroused in that sort of situation than being exhausted and waiting for inspiration to strike. And hacking into your partner's phone and putting a recurring activity called, marital bliss or something like that into their phone. So there's a 10-minute reminder beforehand. And especially if for women who are having difficulties with lubrication, get the goop on, everywhere. Don't stint yourself. And Kate's got some good recommendations about which ones are better than others. And actually sort of put yourself in the mindset. Then you may not be having full-blown sex every time, but you at least are spending that time and hopefully improving the communication in your relationship. Now, there have been efforts to explore various medications that might improve libido, and to date they've either not been well tested in women with breast cancer or not been successful. So the female version of Viagra is yet to be discovered. And the thing that has most often been looked at is testosterone, so male hormones. And in women who have low estrogen, this probably doesn't work very well. So in women who have other kinds of cancer and where their estrogen is normal and having difficulties, then testosterone may be a useful addition. Whether it's good for your long-term health or just deepens your voice or other concerns about side effects is yet to be known. But for women who are in a low estrogen state, which we often like people to be, it doesn't seem to work very well on its own. And some of the other injectables and tablet-based medications don't seem to be either terribly effective or terribly safe. And one of them, called flibanserin, which I've been researching, that you can't drink alcohol with it at all because it makes you faint. So that would be a sort of swooning effect, which might be somewhat counterproductive. So I reckon there's a fortune to be made for someone who finds that magic blue pill, but we don't have it yet. And so we have to work on other aspects of mental and physical preparation.
And when you say that the female version of Viagra hasn't been discovered yet. I mean, how hard have we been looking for it? Have we been looking as hard as we looked for the male version?
Well, I suspect not. And the male version was identified more or less by accident. It was a blood pressure tablet, and it didn't work terribly well. But when they got to the end of the clinical trials and they said to the man, well, we'll have those tablets back again. They said, oh, no, you won't. Actually, quite like them. And because the male sexual response is a whole lot simpler than the female sexual response, it really was discovered more or less by accident. And so there hasn't been the same degree of research, I think. And I suppose there are a number of reasons for that. The rhetoric around this area is very interesting and often talks about empowerment of women to experience their own sexuality. And the other thing that can help with libido is to practice by yourself. And so not waiting for your partner to come along, but actually getting yourself back into the habit of having sexual experiences by yourself when you're not stressed. That can be useful. And Kate's got some excellent suggestions about vibrators and things like that that can be very helpful if your response is a bit slow to make that a little bit easier.
Okay, I'm going to go to Kate and her increasingly interesting sounding shopping list.
Yes, definitely. So lubricants, vibrators.
The Goop shop, and it's
The Goop shop.
Pros probably, although not entirely. Rebecca, I was watching your face when Fran was talking just then, and particularly when she was talking about jumping into your partner's phone and scheduling some time and so on. Is that what you did in the end? Like, did you have to sort of take matters into your own hands a little bit in terms of scheduling, as horrible as that word is in a sexual context?
Yeah, absolutely. I think it was definitely something that I started to do. After a while, I was like, right, I'm ready to get back into this. You know, I don't want to be on the sideline anymore. I still want our relationship and I still want to have a healthy sex life. And so definitely it's something that I think my husband was very good at letting me sort of initiate that, really. And I agree with Fran, sexual pleasure, personal pleasure is very important too. I don't think it's anything that we should be ashamed about. And that, you know, if you don't, and then this is the thing, we're talking about sexual function, but some people don't actually have partners either. So I think that's really important to raise as well. So I think it's something that we need to really take the lid off it and stop being so embarrassed about these subjects.
Rebecca, you're in probably a different point in the whole journey from heaps of other people on this call. And what I'm interested to know from you, keeping in mind that this is an Ask Anything segment, like, has the way that you enjoy sex changed, you know, from before, let's say before you even conceived your child? Because your old idea of what you like to do and what your husband likes to do and all of that, has that actually changed where you are now? Like, have you learnt to do different things and enjoy different things?
Yeah, look, I think probably, when things aren't, I'm a very proactive person, so I try to find a way around things. So, you know, I think there are many erogenous zones in the body that are to be explored. And I think that we shouldn't be focusing on the things that we can't change and really be focusing on the proactive things that we can change and work on as a couple, and whether or not it's, you know, adding lubricant into the mix or it's changing sexual positions to find those pleasure points. I think that's really important to know.
It's a really sad little question in that little montage, and I don't know if this has any relevance to your personal experience, but somebody, and if it doesn't, then maybe somebody else on the panel might have some thoughts. But there was a question that was something like, if your nipple sensitivity has always been a huge part of the way you enjoy sex, and then that's not there anymore, what do you do about that?
Yeah, look, I had lymphedema in my breast, and so it's a weird thing. So you lose sensation, and that like arousal response in that left breast after you've had a lumpectomy. And like I said in the beginning, I knew that was going to happen. I acknowledged it. It was part of my treatment. But I think probably the lymphedema as well, it became quite painful. And so, if someone tried to grab it in a moment of passion, it really wasn't very comfortable. So, and then you have to open up that whole conversation of, well, can you please not touch my breast? It's actually quite painful. It's sort of like you sort of feel really bad having to raise these issues, and because you just want things to go back to the way they were before you had the breast cancer diagnosis, before you had this whole experience, and when things were fun and there was lots of free and easy life. So so I think that's probably something that you need to sort of really work on. Yeah.
Just out of interest, people, for men who experience breast cancer, and they're a minority, but they absolutely are there, is low libido also common to them?
It is actually, and if they're on hormone blocking drugs, then they also can experience erectile dysfunction. And but for them, Viagra does work, and so in that circumstance, that would be, I think, part of the conversation with beginning men on hormone blocking treatment, is to look at what can you do that might be helpful to you in your relationship. And of course, body image may not be affected quite as much because their breasts may not be as much a part of their sexual identity as they might be for women.
Those keeping in mind that there are people on different stages of the journey in this conversation, I would have thought that, when you go undergoing treatment, that it would affect your libido, but then things will go back to normal after you've stopped taking medication. I mean, is that true or not true? Kate?
Look, there's enormous variability, and I think one of the things is, first of all, I think as Belinda highlighted with her study, some of the treatment goes on for quite some time. It might be 5 or 10 years of ongoing treatment with oral medication. So we know that those drugs do. I think the other thing is, and it's an awful thing, but I think someone, Fran or Rebecca, mentioned it earlier, it is a bit like use it or lose it. So the longer you go without maintaining sexual intimacy, then the harder it can be to start, and your desire for it starts to peter off. So if your libido is affected anyway. I think the thing about libido is that there are many times across a woman's lifespan where their libido will, go down the bathroom drain, so to speak, but it sort of recovers. What we have to do, I think, is be really clear about what it is. Is it fatigue and just not having the physical energy? Is it something that's happening in up here, that sense of femininity being lost, worried about their partner stroking their breast, the loss of sensation? And we know that the body compensates, and as Rebecca highlighted, there's other areas that start to become maybe not stimulated in the same way, but it still feels pleasurable. But there's also delayed arousal, and it's often called, loss of libido. But couples need to understand, particularly if they've been pushed into a menopausal state, it's not that they can't desire intercourse. It just takes them longer to become aroused. And if the woman's not aware of that, if the partner's used to certain physical signals and they don't have the normal vaginal lubrication and moisture, then the message that the partner's getting is, oh, she's not interested. So that's where the communication is so important, and understanding the physiological aspects that are actually driving that change. But it doesn't mean it can't be corrected if everyone understands what's happening. And that's why we're, the lubricant queens of the cancer block, so to speak, because, we really are very, very keen for people to understand the difference between using a vaginal moisturiser to prevent dryness or to manage it, and the importance of a lubricant. And it's not using a lubricant in the way that you did when your husband or your partner was using a condom. It's using a lubricant around the vulval region, the vagina, and on the penis, all of those areas, and you want a lubricant that's going to last. KY jelly lasts 3 minutes. So don't use KY jelly is what I'm saying. So that stuff's really important. The other thing that we know that happens over time is the opening of the vagina that's called the introitus. That starts to just narrow. That's just natural with menopause. And so what can happen is it actually hurts when penetration starts, and that makes everybody tense up, and then that can become a sort of self-perpetuating thing because you're worried about the pain. So that's why the lubrication is really important. But if that's been a problem, there's also some other little tricks that we can recommend to overcome that initial pain and discomfort that if you do for a month tends to find that gets better over time. And I guess where I'd go with all of that is it's why assessment is so important, to actually unpack what's actually happening, because it's very easy to say, oh, I've lost my libido, I've got no interest, but it's really understanding all of the factors and what's been happening when couples have tried to be intimate with each other.
Okay, I'm just going to vocalize the women I can sense screaming at the screen. Tell us the tricks for one. Don't buy KY. Well, what are we buying then?
Okay, so there are some. So the thing that I recommend, and don't laugh, but I take tours there, is if you ask your breast nurse or your colleague if there is a good adult shop, a quality adult shop in your near area. I have one, and very embarrassingly, if I purchase anything, she says, I'll give you the sex worker discount, which always... I think of my mother whenever she says that, I have to say. Most of the staff in a good quality adult shop are very experienced and often are doing a master's in sexual health or something, and generally there's always a female. And you can actually go and try and feel the different lubricants so that you actually understand about the different viscosity. And there are different types. So that's about the lubricants. So I just so happen to have one here. So it doesn't have to be the ones that you can get at the chemist or at the supermarket, are things like Astroglide. Astroglide is an Australian company, but it's made in America. So they're a lubricant, but it's good. And try different ones, get samples and see what they feel like, and experiment with them a little bit. Replens is a moisturizer that you can use. You use that a bit differently. It's not used for intercourse. It's actually used to keep the lining of the vagina moist. What's really important and what people don't often realise, it's not just the vagina, it's the vulval region as well. And if you're using Replens, massage it in both in the vulva and the vagina so that keeps that moisture and stops that dryness from occurring. And the final tip I give is if you are experiencing some pain on initial penetration, your chemist will have a topical anaesthetic product like xylocaine cream or xylocaine ointment. You only use a little bit in the bottom third of the vagina and just put it around the bit. It numbs it, but it sort of, if you can relax and just numb sorry, I can't help but use my hands, as you can see. It just helps to get over that initial penetration. And the small study that looked at this found that after a month, women found they didn't need it anymore because they were able to return to having penile vaginal intercourse.
Annabel, I also have had the experience of women complaining about vaginal irritation and pain. And we have in Sydney a number of people who specialise in the dermatology of the vulva. So the vulva is actually skin, and people can get things like psoriasis, lichen planus, etc. So other sorts of skin conditions can affect the vulva. And if we think it's just estrogen deficiency, if we think that it's just, pain from penetration, and it turns out it's a treatable dermatological condition, if you haven't made the right diagnosis, you can't actually get the right treatment. Now, one of the patients this week said, asking your doctor, I want a vulval dermatologist, always sounds like you're being a bit sort of demanding, and they're a little bit short supply, but they are completely impossible to embarrass because everyone sitting there squirming in the waiting room has the same problem. And that would be something I would really recommend. If the usual sorts of things that Kate's suggesting are not helping, there may be another diagnosis.
Okay, well, while we're on specific, issues, we've had a bunch of questions asking about Mona Lisa touch. Now, what even is that? It sounds like a sort of Renaissance era football game, but I'm sure that there is a lot of knowledge about the Mona Lisa touch on this panel. Who wants to go first?
I'll jump in first, and then Fran and Belinda can jump in. So the Mona Lisa touch is it's a component of another machine, actually, but it delivers a low-level laser dose. And a small study came out of Italy about 5 years ago now, maybe a bit longer, which found that using low-level laser in the vagina was postulated that it actually helped to facilitate the recovery of normal vaginal mucosa. So some people might find, if you've ever seen the ads or if you Google it, you get all these kind of ads for vaginal rejuvenation. Come and get your vagina rejuvenated in your lunch break, that type of thing. Because it's really hard sometimes to work out, we've got limited choices and options with women after breast cancer diagnosis. This has generated a lot of interest. And it sort of had a life of its own without having lots of really good research to back it up. In 2018, the FDA in the States put out a warning saying that it's not approved for that use and actually banned it being used in that way. However, it's used in Europe and it's used in Australia. And Belinda can tell you about a study that they're doing. There is a paper, an Australian study that will come out in JAMA in October next month from New South Wales, where Professor Abbott from the Royal and Uni of New South Wales has done a randomised controlled trial where the majority of the women had breast cancer, not all of them, and there was no difference. There was no obvious benefit in a 12-month follow-up. Lots of women are having it done, and I think part of it is because there's something we can offer. Word of mouth. There's some very good commercial marketing happening, but I think what I'd really say at this point is we don't know enough about it yet, and we don't know what's the dose, how frequently, can you go back and have it, all of these things. So it's something of interest, and we need more research. And I'm going to pass over to Belinda because she's doing the research.
Yeah, sure. I think that's so true. I think my concern is that it is sort of this very popular treatment that people are hearing about and perhaps going and having it done by people that aren't as well trained as they could be. And I think without knowing how safe and effective it is, I think we need more studies. So that one that you mentioned that's coming out will be good. We're also doing a small one with women, just with women with breast cancer only who have got problems with dryness and seeing whether it's effective. So we haven't really got the results for our study yet. But I think it's attractive as an option because it doesn't rely on any hormones. So I think a lot of women who are too afraid of using the vaginal estrogens, this might be a safer option for them if it proves to be effective. So I think any women considering it, I guess I'd just be wanting them to do it on a trial where they had someone who was specialised in this and rather than just going to their corner laser therapist who maybe isn't doing it all the time. That'd be my main recommendation there. So I think it's certainly something that needs a bit more study to know how effective it is and how long-lasting that benefit is. I think at the moment they're having a few treatments, but does that last for 3 months, 6 months? I don't think there's been very much long-term follow-up to say does it work for a long time, or as you said, Kate, do you need to have top-up laser sessions every year? So there's still a bit of information we need about that. But again, we need to be doing these studies so that we find out what the options are that are going to work.
Belinda, wonder, just for those of us who have, only today learned about Mona Lisa Touch, how expensive is it? A, and B, are there actually, active risks of harm, do you think, if you strike the wrong practitioner?
So, yeah, I think that putting a laser into your vagina, you could perforate something or burn a hole in something. So I think you don't want anyone doing it who doesn't know what they're doing and doing the right dose and technique. The cost, I actually don't know the cost if you go and have it done routinely. In the trials, one of the things with clinical trials is that it's covered the cost of the treatment. So I'm putting people onto this as part of the trial, so they're not paying. But Kate, you might be able to tell us what the cost is, or Fran, for patients that are paying for it.
I think usually about $1,000 a session, and people commonly would have 3, and then a top-up at a later time. Some of the people in the city here in Sydney who do it give a refund of part of the cost if it's not effective. And anecdotally, there are some women who say, look, it just changed my life. It was the best thing for our relationship that I stopped, writhing around in pain. Many of these treatments have a pretty strong placebo effect, and who cares if it makes you feel better? But it is a reason why when you're designing a trial, you really need to have an appropriate placebo, because if, 30% of people improve on the placebo, that's great news, but it means that you didn't need to laser them to get that improvement. My favourite vulval dermatologist is also keen, if people have vulval pain, that they have someone take a really good history of whether they've had spinal surgery, spinal injuries, or other pelvic injuries from childbirth that might have affected the nerves that innervate the vulva. And pelvic floor physios are often another group who are quite good at assessing this, because the function of all of those things is not just about the hormones and about the surface, but it's also about the deeper tissues. And when you have vulval pain, a fairly common concomitant of that in older women is actually sciatic pain, suggesting that there's something more general going on. And in that case, a small dose of a very old-fashioned antidepressant called amitriptyline is sometimes helpful, and it's used by the chronic pain teams to try and just dial down the sensitivity of nerves that are jangling. And along with in understanding what's happening, if you're frightened that the pain means that something's going to blow apart or tear or hurt yourself, of course the fear factor kicks in and you're going to avoid sexual encounters. And so, overcoming the fear factor is part of how people deal with all sorts of chronic pain conditions, and vulval pain is one of those too.
Fran, I'm sure I speak for us all when I say that I'm delighted that you have enough vulval dermatologists in your life to have one that's your favourite.
Yes, it's nice actually.
Now, before we move on from the vagina, although really do we ever, I wanted to just check back in with you, Belinda, on this next question, which is about lubricants. Do you have anything to add to what Kate said about choice of lubricants? I was getting the distinct feeling that high viscosity is a good thing in lubricants. And secondly, for women who have estrogen-related breast cancer and can't use estrogen cream, what are the alternatives for them?
Yeah, so I think that, like Kate said, I think that lubricants, there's a lot of different ones, and I think women need to try different ones and see what works for them. I'm frequently sort of talking about this with women, and they'll say, oh, I've done that. I tried a lubricant, it didn't work. But what lubricant did they use? How did they use it? So there's a lot of sort of education required there. And I think just going to Coles and buying the supermarket brand may not be the most effective one. And so there are water-based, silicone-based, oil-based lubricants, and the silicone and the oil ones do last a bit longer. So if someone starts off with a water-based one, it may be very good for them, or it may not, and they might want to try a silicone or an oil-based one. So I think just exploring the different types of lubricants. There's some that are organic and very unlikely to sort of cause reactions or itching. So I think there's certainly not just one lubricant for everybody. There's a lot of different ones, and the adult stores have often got a lot of these available as well if you can't find one that suits you in the supermarket or the chemist. And adult stores often have you can often purchase things online. So if you're too embarrassed to go into the store, maybe an online store purchase would be suitable for you. You could get your lubricants delivered. And I think that with the vaginal estrogen, so I guess they are an option, I think, for anyone, even with the estrogen receptor positive breast cancer. So I wouldn't rule them out for anyone. I guess it just depends on an individual. So I think the first thing I would say to anyone is try using a regular moisturiser. So we mentioned Replens, there's a few different ones. And I think, again, using it regularly. So like you moisturise your dry skin or your dry hands, you need to moisturise your vagina. So using it regularly is important. And then using a good lubricant when you're having penetrative sex is important. So if you're doing those things and you're still having a lot of symptoms and dryness, that's when I would then say, well, why don't we try a vaginal estrogen? So there are some women whose cancer was hormone receptor negative, and I think that the estrogen creams are very safe for those women to try. There are women that are on tamoxifen tablets, and tamoxifen actually blocks the uptake of estrogen. So if you're using an estrogen product in the vagina, if you happen to absorb a little bit into your bloodstream, which is, I guess, what we worry about, that it might be absorbed through the vagina into the blood and that might affect your cancer, if you're on tamoxifen, it's going to block that uptake. So I think it's very safe probably for women on tamoxifen. The women who are on the other sort of hormone tablet, the aromatase inhibitors, they work by lowering the level of estrogen. So I guess in those women, we're always trying to avoid giving any extra estrogen. But with the vaginal estrogens, usually how they work is firstly, they're a very low dose. Secondly, initially you use them every day to try and repair the lining of the vagina and get it all to sort of the tissue to thicken up. And then you can drop it down to a maintenance dose, which is often for many women just twice a week. So if they're just using a very small dose in the vagina twice a week, the amount of estrogen they absorb is probably so small it's unlikely to be a concern. We just don't have the data. So I think the studies haven't been done looking at women with hormone-positive breast cancer using vaginal estrogens and following them up for 20 years to say, does it affect their risk of cancer recurrence? And so I think that, I guess I see our role is that we need to let women know about this. We need to say this is an available treatment. We don't have a lot of good data about the safety, but similarly, we don't have any data that says it's not safe. There is more data being collected. There are studies happening. And I think individual women then need to make that decision. Like, I get upset when I hear that people have been told you can never use vaginal estrogens with your breast cancer, because actually for an individual, they need to weigh up for their own circumstances the risks and benefits. And maybe for them, the improvement to their quality of life may be that they're going to potentially accept that potential small benefit that may not even be there. So I think that's why I would like women to bring their concerns to their oncologist and have a chat about it. And I'd hope that most oncologists would be happy to do that and not just shut them down and say, you can't use this, it's out, not allowed. So I think we just need to be letting people know that individuals, it's very personalised what we're doing, and everyone has to sort of weigh up their own risks and benefits.
Thanks so much, Belinda. I'm keeping an eye on the clock and realise we've only got about 15 minutes to go if we stretch. So I'm going to move on to the next subject area, which was really a great fulcrum for questions that came through from all of you. And that's about body image. And I don't know, I'm sure I can't be alone over the last, bank of lockdowns. I think, God, all I do is kind of cook and clean up, and I look at myself in the mirror and I think, oh my God, you are the least sexy creature I've ever seen. But I mean, how much more of a kind of de-sexifier is it to also have your body undergoing all of these interventions and treatments? You feel kind of like you're a lab rat or something, like it's not the sexiest way to feel, is it, Rebecca? And I wonder if you could just tell us about your recollection of how breast cancer affected the way that you felt about your body as a sexual body.
Yep. So to start with, obviously, when I started losing my hair, I really didn't want anyone to see me. And I was a shell of myself. As a sexual being, I guess probably it got worse after a while because I actually was underweight when I was diagnosed. I've gone through this process of actually putting on weight, a lot more weight than I probably should have after my diagnosis. So there's been a lot of fluctuation in my weight.
They're lockdown kilos.
I know.
COVID kilos don't count. All right.
COVID kilos don't count. And but if you spoke to my oncologist, she would tell you that I was underweight when I was diagnosed. So that was a big thing that we had to sort of manage. And I went to a dietitian and had to put weight on so that I could actually do chemotherapy. Part of my chemotherapy, I actually had a major allergic reaction to paclitaxel, and I was covered in this wild rash over my body from head to toe. The only thing that wasn't covered was this part of my face. So you can just imagine that I turned into this lizard. And so I really wasn't feeling that that sex or my sexual being was really in a good space. So I think it took me a while to sort of start to change my sort of thought process, drawing on my eyebrows, and, some days my eyebrows would be up here and some days my eyebrows would be down here. So I think trying to put makeup on and trying to feel sexy, wear nice clothing. I used to wear these really funky glasses and big earrings, and I tried to really, really make the best of a really bad situation. So, so I think that's probably how I dealt with some of those body images, like image issues. And then after my treatment, it's just been about, going and getting my hair cut and trying to really get back into my normal self. So, it's really weird. You can't wear the same clothes that you wore when you were off treatment than you're on your treatment. They just don't look the same when you've got no hair. So, yeah.
And Rebecca, did you feel like this question of body image and how you felt about yourself, was that something that you had to resolve by yourself, or was it something that kind of your husband could help with? I mean, is it hard to talk to your partner about this aspect of what you're going through mentally? Do you feel anxious about burdening them with something else? And do you have any advice for people or their partners about how to deal with this?
Yeah, I think probably, I think it's really important to, be honest, and, you can't sit there and say that everything's rosy and you look beautiful, but, I think some people deal with that in different ways. So I didn't wear wigs, and for me, I just rocked this bald head because I was just like, right, well, I'm just going to make the most of this. I've never cut my hair this short before. But yeah, I think for some women, the hair issue is a really big thing, losing your hair and also losing your breasts as well. I can't talk for anyone who had a mastectomy at all, but that is a huge deal, and the amount of surgery that they have to go through and the delay in having that reconstruction has huge impacts on their relationships with their partners. So, so I think, Glenn was pretty supportive of me, and he still told me I was beautiful and that he loved me. So I was very, very, very well supported. So, it was very nice to have someone like that who just would take me for who I was. So,
hey, can I get some insights from? Well, sorry, thank you. I'm moving along, so I'm thinking about what I want to ask Kate. Rebecca's just said that she can't speak for people who have had mastectomies, but I wonder if you could give some insights into the conversations that you've had and the observations you've made about that impact, because obviously that happens to a lot of people and it is a hugely invasive part of breast cancer treatment. So how do you see women responding to that? And what do you see working for the women who are struggling with it?
It's incredibly variable, is what I would say. And I think what's really interesting, and I know we're going to talk about mastectomy, but the thing about hair loss is that you lose privacy. And, you know, Rebecca rocked a bald head, and I'm quite sure she did. But I just remember a patient last year said to me, yeah, you can tell me that, but I'm 65. I don't want to be a bald 65-year-old woman. So we've got to think about those things as well. I think the thing with mastectomy is understanding how a woman's come to a decision about that, and was there a choice. We do know there's a bit of a problem with people who are in regional or rural cities who may be offered a mastectomy so that they don't have to travel for radiotherapy. So it's understanding the choice and the choice about reconstruction. And also they're understanding whether there's been a real sense of urgency about having to get it done and having the surgery. Women will go to great lengths to conceal that they've had a mastectomy. And one of the things that they often talk about is the challenge of how they change their wardrobe. So, you know, no longer wearing things with a V-neck, for example. And feeling very self-conscious. And it takes quite a bit of time sometimes for people to feel comfortable to wear a swimming costume, for example, particularly with a prosthesis. And it takes a lot of confidence to be able to laugh about the fact that prosthesis came out in the surf and they had to get someone to go and help them find it. Most women that wear prostheses have stories about moments where they found it quite difficult. Everyone responds quite differently. And I think that's the thing, is to sort of talk through what it means to them, what do they anticipate how they're going to feel, and then working with them around that. So if it is about changing their clothes, what are the sorts of things? Some of the things I've learned from partners, and one partner who stands out, whose wife would turn away every night when she got undressed for bed and insisted on wearing pajamas again. So she, you know, changed their sort of whole thing. And he kept saying, oh, but I think you're beautiful. What he did, which I think is really clever, is he went out and bought her these incredibly sexy, semi-transparent little cami tops. And his message to her was, and he said to her, you are very sexy to me, but I understand that you don't feel that way. So he was meeting her halfway, and I think it goes back to the point about Rebecca saying husbands want to do the right things, partners want to say I love you, but sometimes by saying it makes no difference or I think you're beautiful is not actually hearing how that woman's feeling. And sometimes it's more helpful to just say, tell me what that is like, you know, to open up. You can't make it all go away, but giving women an opportunity to talk about how they're feeling is incredibly important, and dismissing it or not acknowledging it is not helpful.
Such a great series of observations. Thank you, Kate. I'm barreling through now because there's two really big questions that I really want to get a little bit of feedback on before we have to wrap up. And the first one is about menopausal symptoms that come about because of breast cancer and treatment. Fran, a lot of women are very worried about this. And can you just give us a quick assessment of it? I know it's unfair to ask you to deal with this quickly. Is there any relief from those symptoms, and can you get relief without hormone replacement therapy?
Hormone replacement therapy covers a sort of multitude of ills. So it is the fastest way to cover most of what happens at menopause. If you don't want to use hormone replacement therapy, you've got to kind of pick apart the puzzle and say, which are the things that are the most troublesome? So for some women, it'll be hot flushes. Let's try an antidepressant. For many women, it will be musculoskeletal pain. And that's actually a lot harder to fix and can be much more long-lasting. And so that's where your good physiotherapist might come in, or some anti-inflammatories, or a rheumatologist in case you've uncovered some other underlying arthritic condition. For some women, it will be sleep. For many women, it will be sleep. And a couple of years back, there was some really nice research done about what it is that causes hot flushes and sleep disturbance in women, what's the wiring. And it turns out that your thermostat's been reset. So instead of having about a degree centigrade between morning and afternoon that you can tolerate, you kind of only tolerate half a degree. So you not only get too hot, but you also get too cold. And what you wear may be very important. So having clothes that you can fling off at a moment's notice. Now, when you're my age, everybody's flinging their clothes off at a moment's notice. And so all the grey-haired amongst us, nobody is surprised at that at all. And of course, Rebecca's experience is that when other people are deciding, am I going to have baby number 2, she's having hot flushes. And I think when you're having a life event, even a normal one, even that you might have experienced as a shitty menopause like me anyway, if you're having that at 30, that's wrong. That's the wrong life part to be experiencing. And I'm sure that makes a difference, as Rebecca said, not having someone to talk to. So that's where you nurse, that's where you cranky old oncologist who's menopausal and understands what you're talking about, and your GP, maybe people who are able to help you with those symptoms.
Rebecca, again, I can see you really responding to what Fran's saying. I wonder, can you contribute any kind of lightning insights into what that experience was like for you and what helped?
Yeah, so I accept that a lot of these are part and parcel of my treatment, and as a patient I've decided to maximise my treatment due to my age and stage. So I accepted that they were part of my treatment, but I think probably I didn't really know what it meant for me long term, and I still probably don't know because we're only year 3. I've got another sort of 5 years of ovarian suppression unless the soft and textile updates tell me otherwise. And then obviously tamoxifen as well for 10. So at this point, I do get hot flushes a lot, and I don't know whether or not that's going to increase or stay the same as it is now, and definitely get the low libido. I definitely have insomnia as well, and I end up getting so hot and bothered that I end up walking out and walking into another room and sleeping in another bed because I just can't handle anybody around me. So so I think probably look, I accept I'm at this stage, but I do think that we need to work on these quality of life issues, because obviously if I'm going to be living longer, these issues are going to be bothering me long term. So it's really amazing to see all these researchers who are actually interested in quality of life studies. I think it's a positive push towards acknowledging survivorship and the struggles that breast cancer women suffer during this period.
Oh my gosh, I could kiss you, Rebecca, because you've pretty much summed up and concluded and tied a little bow on this whole session. Thank you very much. I do, and I know that we're a couple of minutes after, but I know that a bunch of women have asked about fertility and their chances of becoming pregnant and how that will be impacted by their cancer treatment. And so just briefly, Belinda, I wanted to just throw to you to give us the bird's eye view of that giant question that will be huge in the minds of a lot of women who are of a recent diagnosis.
Yeah, so I think that the main thing that affects fertility is chemotherapy. So women that have to have chemotherapy at a young age, the chemotherapy can affect their ovaries. So any woman who is needing to have chemotherapy, we would refer them to a fertility specialist to talk about the options for preserving fertility. So having a cycle of IVF, saving some eggs, or if they've got a partner, saving some embryos and having them frozen to use later would be what we would recommend. So we will often recommend women do that before they start their chemotherapy, and it is safe to do this in breast cancer, and IVF technology has improved now that it can be done pretty quickly, so you're not really delaying your start of treatment very long. The other thing that has been shown to be effective is actually giving one of the hormone blocking injections that turns off the ovaries during chemotherapy. This injection sort of puts the ovaries to sleep, so it kind of puts you into a temporary menopause, but that can protect the ovaries from damage from chemotherapy. So as well as trying to get people to save some eggs or embryos, we would also then recommend having these injections during chemotherapy to try and protect the ovaries. I have a lot of patients who have gone on after their cancer and chemotherapy to have babies, so it is possible. Some of them have fallen pregnant naturally, some of them have used IVF, so I think it is a possibility. I think the older you are having chemotherapy, the more likely it is that you won't be able to have children. So I think as you're getting into your 40s and having chemotherapy, and we already know that fertility falls in your 40s, so having chemotherapy makes that very hard. So I think that certainly the older you are, the closer to sort of 40s and 50s having chemotherapy, it's much less likely that you'll be able to have your own children, but that's when we'd sort of be looking at other options, using donor embryos or other options for having children. But it is a big thing, and it's a horrible thing that some women have got to deal with when they're trying to get their head around the diagnosis, what surgery they're going to have, do they need chemotherapy, they're going to lose their hair, and then you're hitting them with these questions: do you want to have children? If you do, you need to see a fertility specialist and start freezing your eggs, and it's just overwhelming. So I think that there's just so much to take in at those initial consultations with women, particularly young women, when fertility is a concern.
Linda, that was a great overview and just as crisp and concise as I was secretly hoping it would be, because we're well over time now. Look, we could talk about this forever, and the volume of questions and the intensity of interest in this session really shows that there's a lot of talking to be done. I'd like to thank everyone on our panel for their advice and guidance, and thank you to everyone who's joined us today and asked questions. If you're joining this because you're at the beginning of this strange journey, then I hope that you're reassured by the depth of compassion and expertise on this panel. There is a lot more of it out there, and I'd like to thank all of our panelists for the contribution they've made to broadening the discussion about quality of life. And I'm also thankful that unlike 20 years ago, quality of life is something that we're talking about in addition to extension of life. This Q&A has been recorded and will be available on the Breast Cancer Trials website tomorrow, and the team will send everyone a link so that you can watch that or share it with others who you think might be interested in what we've talked about this afternoon. Breast Cancer Trials, who I'd like to thank for having me and helping me learn a bit more about this field, is committed to improving outcomes for women with breast cancer through clinical trials research, just like what Belinda's working on at the moment. And they also look to the community to help support this research. And so if you're interested in cooking, which I certainly am, you might want to participate in their 3-course challenge, which is a fun event where you cook a 3-course meal to raise funds for breast cancer research. You don't have to be a very good cook. You just need to have a sense of adventure and some pots and pans. One of Australia's top chefs, Sarah Todd, will help you out in exclusive virtual cooking class, which sounds worth the price of admission beyond even the fundraising capacity. So you can find out more at 3coursechallenge.com.au. But mainly, thank you so much for joining us. It's been such an enriching and frank conversation. I'd like to thank our panelists, Fran, Rebecca, Belinda and Kate, and wish everybody in this enormous online group the very, very best, and all our love and support in whichever part of the journey that you're currently on. Thank you, panelists. Thank you, attendees. And it's good afternoon from me.